to move towards illness to wellness and ensure that the entire SHM team works in creating healthy India, lives up to the dreams of our Honorable Prime Minister. And with these words, I'd like to thank all the panelists for coming here and sharing their thoughts with us. Thank you.
Thank you, sir. So, ladies and gentlemen, let's have a huge round of applause for the dignitaries present here on the dais. And I would like to extend a warm thank you to all the dignitaries for gracing their occasion, gracing their presence here at today's summit. Thank you, sir. And ladies and gentlemen, with that, we move on to the next session, which is subjected on strengthening the healthcare workforce. And for introduction and context setting, I would like to invite Dr. Rajesh Kesari, founder and director, Total Care Control Delhi, Delhi NCR, and EC member, RRSDI. Over to you, sir.
Thank you so much. Everyone who's present here. And believe me, we are going to have a very interesting discussion right now. Even though it is more related to policy, but we really have stalwarts, people who have great experience in managing hospitals and institutions. So I would be inviting on dais for the first session, Padma Bhushan Dr. S.K. Sareen, sir. He is a senior professor, Department of Hepatology and Director, Institute of Liver and Biliary Sciences, New Delhi. Dr. Sareen is here. Okay, then I'd like to invite Padma Bhushan Dr. T.S. Clare. He is the chairman, Fortis Heart and Vascular Institute, Fortis Memorial Research Institute, Gurugram, and Fortis Hospital, Vasant Kunj. Welcome, sir. Thanks a lot for sparing time and being with us. Next, I would like to invite Padma Shri Dr. Mohsin Wali. He's a senior cardiologist and former physician to the President of India. He's been inspiring us with his knowledge and imparting knowledge, participating in our discussions throughout our webinars. Same as Dr. Clay. Thank you, sir, for being with us today. I would like to invite Dr. G.C. Khilnali. He is the chairman, PSRI Institute of Pulmonary Critical and Sleep Medicine, and former professor and head, Pulmonary Critical Care and Sleep Medicine, All India Institute of Medical Sciences. He's been a very active participant in all our webinars. Thank you so much for being with us, sir. I'd like to invite Dr. Ashish Chaudhary, Managing Director and Senior Consultant, and Head Department of Orthopedics and Joint Replacement, Akash Healthcare. I would request Dr. G.V. Divakar, who's the Managing Director, Divakar Specialty Hospital, CEO and Chairman, Artist. Sir, welcome on the dais, and thanks a lot for coming all over from Bangalore to Delhi for being with us. Thank you so much. I guess everyone is... Dr. Sareen would join us shortly. He is on his way. He'll join us virtually. I'm sorry. He'll join us virtually. So can we put him on? Yeah. So I would like to start, since this discussion is more on policy, I would like to start with a shloka. And this shloka is from Chanakya Niti. It goes like this. Dhanika Shrotriyo Raja Nadi Vaidyastu Panchamaha. Panch Yatra Navidyante Natatra Devasam Vasit. Now this was written by Chanakya, and the significance of this is do not stay for a single day where there are not these 5 persons. A river, a physician, a wealthy man, a Brahman, well-versed in Vedic lore. So this was the importance of physician, doctors, attributed to even in our ancient times. And we've all very well understood the importance of doctors during the COVID times. We've all seen that, and there has been a lot of discussion, so I won't go into these. I would just like to mention some numbers that there's an acute shortage of doctors. We are short of at least 15 lakh doctors. The population to doctor ratio is 0.65 to 1,000, whereas WHO recommends 1,000. India has a shortage of skilled healthcare workers. As of now, we have 33 skilled healthcare workers per 10,000, where we should be having 44.5. So the numbers are huge. We have almost 70,000 hospitals, majority of them in the private sector. So private sector plays a very important role. 80% of the medical expenditure till recently was out-of-pocket expenditure. So how to overcome these barriers, how to strengthen our medical system, I would request all our esteemed faculty to share their views. We've seen the COVID times. When it started, we've seen the first wave. So I'm sure all of you would have experiences from that. I would start with this, and I would request Dr. G.C. Khilnani, sir. So what was your first impression, because you were probably one of the few specialists who had to deal with COVID head-on? How did it start?
Thank you, Dr. Kesari, and thanking Mr. Rajput for making me part of this important deliberations. And I have been involved, as Dr. Kesari mentioned, with several webinars organized by this eminent organization. I was indeed associated with COVID right from the beginning, being a pulmonary critical care person. As the COVID came in 2019, the Delhi government formed a committee under the chairmanship of Dr. S.K. Sareen, who is one of the panelists, and the 3-member committee was formed to look into the preparedness of Delhi for incoming COVID as it was coming. And believe me, we actually discussed, if there are 10 cases per week, what will we do? If the 500 cases per week, what will you do? When the 1,000 cases will do, what will you do? But we didn't know that it goes into lakhs. So why I'm bringing up this issue is that preparedness of health got totally exposed during the COVID. And we saw it all. It's not only that I saw it, every citizen of India saw how the healthcare system came crumbling down. Now, one of the few data that being a critical care physician, and I think this branch of medicine has progressed quite a bit, but it got totally exposed. Now, India has got about 95,000 ICU beds. India has around 48,000 ventilators. The number seems reasonably well, but if you go into the data and what is the impact of that, I'm just trying to have the effect of infrastructure, and I'll come to healthcare workers later. So United States have per capita or per 100,000 about 34 ICU beds, where India has only 3. And United States was the only country who was deficient in critical care. If you talk about the data, you compare Germany with Spain and France. Germany had the minimum mortality in ICUs because they had number of ICU per capita was much more than France and Spain. And this is the data. As far as the other part of the COVID had taught us that we needed much more ICUs, much more ventilators, much more oxygen, much more wards. If I talk about respiratory health, which is my field of specialization, 32% of the global respiratory illnesses are in India, and India has 17% of population, as you know. 28% of Indians are using tobacco in some form. 5 to 10% of Indians are asthmatics, and if we talk about tuberculosis, we are still 4 lakh people are dying with TB, with the 40% people infected with tuberculosis. And lung cancer remains the number 1 cause of cancer mortality all over the world and India. Dr. Kesri has already pointed out. I just want to emphasize one thing, that when you talk about healthcare system, you talk about doctors, number of doctors, number of medical colleges. But if I take example of intensive care, what determines the outcome is not only the doctors, it is actually the staff nurses, which have not been given adequate importance. It is about the lab technician, it is about the paramedical staff, their behavior, their competence. All those things will actually matter in the outcome. If you go to a developed country, you cannot enter an ICU unless the staff nurse permits you that you are properly sanitized, you are not wearing a necktie or whatever their parameters are. So therefore, the Indian system, I won't be long because the Indian system has improved, but there's a lot to be done as far as the healthcare workers are concerned. And sadly, India is spending only 2.1, 2.2% of the GDP in the healthcare workers. The Honorable Minister has left, but I wanted to emphasize, the Chairman of the Standing Committee, I want to emphasize that this is minuscule of what other countries are spending. That is why our healthcare system, and that is the reason that, as you said, that 80% of the expenditure is coming out of pocket. By that analogy, 60% of the critical care is given by the corporate and private hospital, only 40% by the public hospital, and how many people can afford that? Other thing I want to bring out, the discrepancy between the urban and the rural. There are states like Gujarat and Maharashtra, they have more doctors than actually required or projected in the cities. But what about the rural area where the most of the India stays? So there's a lot of things to be discussed. I'll stop here and hand it over to Dr. Kesri.
Thank you so much.
I've just set the ball rolling for
Yes,
that.
yes. Thank you so much, sir. You pointed out some very important aspects, discussions which we would carry on forward. Welcome, Professor Sareen, sir. He has already joined us virtually. So I would start by putting this question to you. Well, we are talking about healthcare professionals. We are talking about doctors. One thing which I have noticed in my short period of practice is that I'm sure many of those who are present, who are from Delhi, would know that there are hospitals in Delhi in which all 3 generations of doctors, the family members, they're all doctors. And they're working together in one hospital. But even that now is passing away. The young generation is choosing other professions. So what's the reason behind this, sir?
Thank you, the SOCHM and Rajput Sahab, and for inviting me. I wish I was there in person. And thank you, Dr. Kesri, and you have been amazing. I have been hearing what you have been saying and the background. I want to take further something what my dear friend Dr. Khilnani said. I want to bring a story, and I want you to remember this story. In 2006, a case report was published in one of the thoracic journals, thoracic surgery journals. The story was of a district hospital. When she reached there, maybe in about 7 minutes, remember 7 minutes, she was blue because she had taken a lot of snow and the water had gone into her lungs. So when she reached the emergency, She was blue. The people pumped out the water, and she was put on a membrane ventilator on the ECMO. And finally, just to cut the story short, she had brain, so her clots were taken out in the night. She had a cardiac problem, it was settled. She had coagulation problems, which were corrected. At the end of it, can you hear me?
Yes. Yes, sir, we can hear you.
At the end of it, in 2 weeks' time, this girl could walk away. But she was not in Brussels. She was in a district kind of a hospital with a capability of any of our district hospitals. So the people asked, how could you save this girl? So the answer was from the nurse, and she said, out of 166 things that we need to do, we did 164 correctly, tick, 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 and the patient survived. So the message remains, it's just not the doctor, it's the team effort, the quality of nursing, the quality of paramedics, and of course the quality of infrastructure needs to be decentralized. Today, when you ask me, are we doing well for the healthcare? I think we are totally lopsided. I mean, it's a good idea to open medical colleges, but you need to have a pyramid structure. We have forgotten that our MBBS is as good as it should be. It is not. It must be an Indian medical graduate who can handle 550 emergencies. This was the Medical Council of India's recommendation in the Vision 2015, that IMG is as good as a team leader, but we have lost. Every medical MBBS wants to do MS, MD or DNB and then wants to do further. It is good. So when you ask me 3 generations are working in the same and still the doctors not enough, I think we have ready available doctors. We need more, but 100,000 medical seats is reasonable. Now is the quality, but also more important is the paramedics and nursing and their quality. This is part 1. And since I have to, I would request you to allow me to speak 1 or 2 more points. Second is that we have totally outsourced our health to doctors. I think there was time when the home, the mother, the father, the others in the family or teachers in the school would look after, and there was a concept of having only for serious problems going to hospital, but now for common problems, gas or discomfort or somewhat bowel problem, everybody would rush. So I think most people should do home remedies or do things, and only we should go to a level of this. And in this regard, today 1/4 of India has fat in the liver, and we proposed a bottom-up approach, and I want you to hear, and I want SOCHM to kindly help in this mission. A bottom-up approach is to start from a village where you have 5,000, 10,000 people and there is an ASHA worker. She just does one thing. She asks in the whole 5,000 village, भाई किसी को BP है, किसी को diabetes है, किसी के घर में cancer है, she makes a list of them. या आपको, the villager has anything. Her job is only asking questions, nothing more. Then she segregates those who are high risk or have a family risk metabolic syndrome, and then she sends them to a next level CHC where there are 30,000 capacity. There is a slightly better facility. At CHC you further segregate, and then after that you further segregate to a district level and similarly higher levels of things. So the bottom-up approach is the common health related issues must be solved at the lowest level easily, and then only those who are referred. Now if you remove fatty liver or decrease fatty liver, all NCDs decrease. It is the mother for diabetes, blood pressure, heart disease, kidney disease, and to some extent even lung problems and all cancers. So my second message First is to have infrastructure for paramedics and nurses. Two, don't outsource everything for healthcare workers. Handle it yourself. Look after your body. Don't outsource. And third, have a bottom-up approach starting from villages for us to decrease the burden of non-communicable diseases. I will add one more point, Kesri sir, is that we have, as of now, awareness is lacking. I'll give you an example. I see generally liver patient जो थोड़ा बहुत मुझे आता है, उसमें patient आया, उसका आज ही के 2 cases. Bilirubin is 27, and this guy has been having this high jaundice for almost 1 month. मैंने पूछा भाई तो तुम्हें तो शराब छोड़ देनी चाहिए थी. बोले सर किसी ने बताया ही नहीं. मेरी बताने की बात नहीं है, but people continue to drink despite jaundice. People continue to take antibiotics, painkillers, despite knowing that they can cause damage. So my suggestion is awareness of what not to do or when to go to a doctor is also very important. In your awareness campaign, and I would be very happy to continue to join hands, the awareness part has to be done. And SOCHM can lead. We have such good people around, a task force, a decentralization of healthcare, in my mind, can help a lot. Not that everyone needs to go to hospitals or doctors. I hope I have answered some of your questions.
Yes, sir. Thank you so much, sir. In fact, we had one question, one idea that we wanted to propose was to create a workforce at grassroots to address the non-communicable diseases, obesity, diabetes, hypertension, diagnose early and move on the way you have suggested. I think that is a very important idea, and we'll carry forward the message to the concerned departments. Thank you so much, sir. I was just going through, sir.
Thank you so much.
Thank you,
if
sir.
there is something more I can answer right now, I would be happy. Else I have my worthy colleagues there who can carry this forward.
Thank you so much, sir. Thank you so much. So nice of you to have joined us. Thank you. Thank you, sir. I was reading a report that almost 30% of doctors and 50% of nurses, even though they are educated and they have the degrees, but they are not involved in the healthcare, or they are just not available. So my question to Dr. Clare, sir, would be, so why is it that despite having this workforce, they being trained and many of them on government resources, public resources, they are not available for the general public?
Well, I think before I answer this, I just want to say, share a little bit more data with you. This is the National the Finance Commission 2018. So as some people have even pointed out that we have one physician for 1,500 people. We have, the recommendation is 1 in 1,000. And in Nagaland, for example, there is one doctor for 17,000 patients. In Goa, 380, there are more than required. So there is a lot of maldistribution. Nurses, the WHO recommends one nurse for 360 people. We have one nurse for 670 people. Again, we are far behind. And in Jharkhand, one nurse for 4,000 people. And in Kerala, they are more than required, 1 in 111. So in these data, the worse in if you take the major states like Odisha, UP, Jharkhand, Chhattisgarh, they are the worst of states. Hospital beds. India has 1.4 per 1,000 people beds. USA and Western world, they have little more than 3. China has more than 4 already. So there also we are very poor, and as somebody has already pointed out, that the more than 65 to 70% healthcare now is private sector, and out of total people, 70% they spend out of their pocket. So what is the solution? Basically, question is what can we do? What should be the policy? In India, I think I am more concerned with the lack of nursing rather than the lack of doctors. First of all, we don't have adequate nurses. Secondly, we don't have enough trained nurses. There are nurses with very poor knowledge, they are as good as nothing. So I think the nurses in this country, they get the least salary and the least respect. Neither they are respected nor they are given salary. So I think we have to have a policy that I think the starting salary of a nurse should be 50,000 rupees. If you compare with the rest of the world, we pay them peanuts and we don't even respect them. And actually the most important link in the healthcare is nurses and the paramedical staff. It's not doctors. Somebody already pointed out, we see the patient and we give orders. Who is going to do that? That's the very, very important link we are missing here. And then we come to the question of, so in my opinion, right to health, there should be right to health. Yes, now Rajasthan government has announced that. I don't know what that means to the people of that state, but right to health should be a national, right. Right to education should be for every child. And then somebody already pointed out, right to gracefully die should also be incorporated into our healthcare system. There are people lying in nursing homes for 1 month on a ventilator. This is all, drainage of resources and just giving too much of, mental and physical, mental and financial burden on those people. So I think India should introduce that euthanasia component. To my mind, it's very, very important. It's not the quantity of life which matters, it is the quality of life which should be matter. If your quality of life is not good, there is no point in living. So those kind of rules and regulations have to be changed. Then I would say that there should be mandatory insurance for everybody, 100%. It should be rule. There is a rule that you can't drive a car on the road without insurance, but we can dance on the road. There has to be insurance. Now people who can pay insurance themselves, they should pay themselves. Then they are who are employed, government or private, 50-50 both should participate, and the people who can't pay, the government should pay the insurance. After all, we all pay taxes, where that goes. If we have a pan assurance in the country, I think a lot of problems will be solved. So you don't have to do many schemes. I wish is in that direction, but it should be much more on a national basis that there should be must insurance for everybody. Now coming to the question of health education is very poor in this country. I think health education can change a lot of things. Now I tell you that in 19, there were 18 million cardiovascular deaths in the world, 18 million. And there is the WHO data to show that if we had adopted a healthy lifestyle, like no smoking, treatment of hypertension, diabetes and yoga, 70% of those premature deaths are prevented, 70%. So thus saving millions and billions of dollars. Now in India, I see there are 50 or 60 spiritual channels. There are Babas. There is no health channel of country. There is no national health channel. At least we can make one health channel which can run from 7 a.m. to 11 p.m. and they can call various specialists to teach these people. There is none. Then we need to introduce a minimum health curriculum in schools. And that can be discussed among various specialists at what age, 6th class, 7th or 8th or whatever. But I think there is a need to introduce that health curriculum in schools. Like there is a 9-year girl, her dad was smoking, so I told her that why don't you tell your dad? She says, I didn't know that smoking is bad. She had no idea. So health education can bring a lot of change. Now coming to the another thing which I would like to say is the quality of our staff. Now quality of staff here, there is a lot of politics. First of all, I think in the medical field we have to decrease the reservation. And this is in medical field, I don't understand the meaning of reservation. Yes, I'm not totally against reservation, but reservation only to far-flung areas where there's nothing there. Then reservation should be based on finances, not on
economic
jati or anything else. There are people whose dad is IAS officer, but children are still getting reservation. Those things have to be looked into the question. And if we want to retain our health pool, we have to create local situations which are lucrative for the healthcare people.
Exactly.
And lastly, before I stop, I think government of India should be very strict to provide security to the healthcare workers. The way the doctors are being treated in the society, is terrible. And actually, somebody said, doctors are telling their children not to join medicine now because there is a documented data in India, doctors live 5 years less than common people. There is a documented.
Yes, yes.
So these are the issues which I would like to say.
And in fact, what I wanted to say, the thing that I started with was that when I was studying, most of my teachers, professors, their kids were doctors. And it was a very honorable profession. But now when I see my seniors and colleagues, their kids don't want to be doctors. So I think this itself is a very important message that goes with it. So yes, thank you, sir. We'd had some very, very interesting and I would say very useful suggestions from you, and we'll definitely make a note of them and pass them on forward. Dr. Vadi sir, I would like to ask you, so do you think that the institution of physician is being neglected? That people and our medical science is more focused on specialties, super specialties, whereas we need more physicians, more diabetes care nurses, or such individuals?
Thank you. Yes, answer is yes. You know, I'll be very short and crisp, but let me wish this organization, ASSOCHAM, with which I am associated for quite a long time. And the day, Anil Rajput Sahab, you have chosen today is Indian New Year. I wish you all a great Indian New Year ahead and success to your mission. And this is a very important mission, saving lives. You know, we can read a lot on strengthening healthcare workforce in India. It's online. But the question which you have asked is very important. You just spoke about the honor and previously spoke about that 15-year-old diabetic boy you caught just suddenly, and it's like, first thing I will say, honor begets honor. Previously, the era you were talking, the students from respectable families who knew the values and also knew value of life were becoming doctors. Unfortunately, I'm speaking a little out of box also and a bit emotionally also. Please take the message home, what I'm speaking on my 55 years of experience, is that in between, you remember there were only 6 medical colleges. Then the mushrooming of medical colleges took place. So the noble medical profession became a business. People purchased the seats and now they are earning this amount which they have spent in purchasing the seat. This medical profession cannot become business. Never it can become a business. It's a profession of giving, giving and giving. It's a profession of respect. It's a profession which is sometimes labeled as divine, even now, but was always labeled as divine in the past, full of respect. So this respect, I thought, was coming from the values from families, joint families, especially where from I learned the values from my grandmother or grandfather was not alive. Then I learned values from my father and mother. And that also came from my best teachers. The teachers of my generation were different than the teachers of today, including Google. So there is a major change, major diversion, and I fully agree what Dr. Claire said and what all of us have said, that it's a collective responsibility to the community, and we as the doctors are answerable to the people who are our beneficiaries for their spiritual health, mental health, psychological health, sexual health, apart from physical health. It's a big responsibility. You see, we are the healers. The doctors are the healers. We are not producing healers. We are producing robots. And I tell you, in next 20 years, we will have so much robotics in medicine that all the doctors will become infructuous. You have been seeing apps coming up and doing the work. So what's the need of doctor? No, there will always remain the need of that doctor, which is called charaka, which is called shushuta, and in our days, which is called a clinician, C-L-I-N-I-C-I-A-N. The clinician has to diagnose it. It's not a gastric pain, it is a cardiac pain to be sent to Dr. Clare, and the life is saved. If that clinician does not diagnose cardiac pain correctly, the life is lost. So this is a major difference in what your basic question was. And I would also say one thing very important relating to your 15-year-old boy. I have done many surveys in schools when my kids were in schools, and I have found on an average of 5 students in a section of 50 multiplied by 5, that is 2050, were hypertensive. Strangely. So catch them young. All the patients which come to us, they have exhausted their system, they have exhausted the reserves, like in your diabetic book when I brought that famous pink book. The first thing which I learned from that book, that diabetes becomes evident when 30% of the pancreas is already damaged. So we have to save liver, as Dr. Sareen said, we have to save pancreas and many organs. Kidney, similar way, does not tell us when it starts damaging. The GFR goes down. So all these organs, I will just conclude by saying, can be saved by what Mr. Anil Rajput has drawn at the top of your logo, a mortar and the piston with a tulsi leaf above the staff, above the medical staff, and I fully agree with this drawing. Because we have to heal at home. We have to heal at home. The Dadi Ma ke nuskhe. You know what Dr. Sareen was telling means everybody having a pain on the right hypochondrium is coming to ILPS. That's what he was conveying. That patient doesn't need to go. Like I have been giving examples of every headache patient goes to neurology, OPD names. No, a simple headache doesn't need to go. In that going 50 patients, one patient who has a brain tumor can be missed. Now, the final thing is, in the light of what you have asked, we cannot produce good doctors unless we give them sanskaras. Sanskar, that's the right pronunciation. We try to make them good human beings. We try to teach them Dr. Shikha Sharma's diet, best diet for them. You see, last week there were posters and logos and displays of Shri Ann and the Prime Minister Modi's photograph. This was the basis of health. It was not just a Millets Day or International Year of Millets. This was the health. This was the health that we have forgotten. गाँव का आदमी, गरीब आदमी जो बाजरे की रोटी, बगड़ की रोटी, चने का साग खाता था, उसको डिस्लाइपिडीमिया नहीं होता था. मेरे फादर साइकिल चलाते 93 years की एज में उनका एंजियोग्राम नॉर्मल था. The last day of his life he climbed the stairs. So Dr. Anil Rajput is sitting in front of us. He is an embodiment of perfect health. He and his wife. It is here. That is why he is delivering things. Unless we practice, जब तक हम practice नहीं करेंगे, हम deliver नहीं कर सकते. All the doctors who talk about dyslipidemia, they come out and eat 5-star meal, drink alcohol. So we have to really be saints. If not become saints, be a good human being and deliver the medicine like medicine of India. We don't need very fanciful medicine. What I mean to say by giving this statement is strengthen the primary health care. This is what the recently revised policy when Honorable Mr. J.P. Nadda was a health minister, he put maximum stress on improving primary health care. The Pura Hall and all of us would unanimously agree to this, that unless we strengthen our primary health care, we cannot march ahead. We have produced the best doctors who are leaders in the world internationally. I always say our doctors are the best. We have always the best teachers. So don't forget that we are short of faculties, we are short of nurses, we are short of doctors because of the reasons you have just now mentioned. So the medical profession will command respect only when we are good human beings before being a good doctor. And I repeatedly find such an example in Mr. Nalin Rajput and many of my senior colleagues. Dr. Khilnani is sitting here. Sir is sitting here, Divakar sir. So the generation gap is going to be very drastically dangerous if we forget to make our doctors good human beings, and my stress is always on that, and catch them young, go to the schools, put a curriculum of health, yoga, and what we need to practice. Our nation's health is in jeopardy. Every house you go in a bigger city, in the morning you find the tables laden with the empty boxes of pizzas and fast food. While the parents are sleeping at 2 o'clock, the children are they are paying online, the door is locked, they just open. If the gate is locked, he delivers it through the gate. And what they are eating at night when we are sleeping tells the future of tomorrow's India. This is very, very dangerous trend. Please be kind to watch this. Our nation health is not what we have today, but our nation's health is what our students who are in class 6, 8, 10th and 12 and in colleges, smoking, drinking, dancing late nights. So that is the Indian health. We have to come back. Otherwise, we will lose our seats from NASA. We will lose our seats from American universities. And what they exactly mean today is happening. Sorry for this statement, but if we are good in our best in our performance, if we are meritorious, if we are sattvic, if we are practicing brahmacharya, if we are practicing yoga, if we are practicing dharma, if we are practicing even Sanatan, I would say, being a Muslim, I would say Sanatan, even if we are making ucharan of Om, that Chandrabindu of Om has got sign in 8 countries' national flag. So this is nothing religious in Om. It is everybody's Om. So please watch your children, watch the generation from being trapped into what we are assembled here today. Good health is a big word for tomorrow. If we have got good acharanas, and good acharan comes from respect, respect comes from satisfaction, also respecting our elders and following dharma, religion, whatever we have, and eating right and behaving well. And bigger epidemic than this disease is tomorrow's mental epidemic. We have already talked of mental epidemic, but what I percolate from the distillate of mental health is the mental health of youth. New epidemic, leak of paper, 20 suicides next day, 200 suicides next day. These are the new epidemics which are not yet documented in the Western books. How a small paper leak 5 minutes before or 40 minutes before the exam can cause 200 young deaths. People never died in IITs. People never murdered their parents. People never cut the bodies into pieces. What is this happening? This is here. So we have to treat this epidemic also. I'm sorry I've taken a little extra time, but please, you will not hear this from anyone, what I am talking. Treat the mental health of young and adolescents. See them watch them what they are doing at home. Watch their computers, their mobiles. Otherwise, we are going to have a big epidemic of human lives lost, which will be disproportionate to anything documented so far. I'm sorry I brought certain salient features of the society, but truth is truth. Thank you.
Thank you so much, sir. Thank you. I think you have mentioned some very important points, that the health starts, the care of health and prevention of disease starts not when the disease has already arrived, it starts very early. As we know, diabetes, the foundation of diabetes is laid already not in the kid, but in the womb of the mother. So this is where we need to start the primordial prevention. We are going to have a session on this, so I won't speak much about it. So carrying on the baton ahead, I would like to come to you, Divakar sir. Sir, you are from the field of ophthalmology, and in ophthalmology, we know that there have been great strides, especially with participation of non-government organizations. There has been a lot of sponsorship for operations, surgeries, for prevention of blindness. Since we are talking about strengthening our workforce, how to deliver better, how to increase the outcomes and how to deliver healthcare both quantitatively and qualitatively. What is your experience and what would be your suggestions, sir?
Thank you very much. I thank, first of all, the SHM team and Anil Rajput for inviting me for today's panel. We know that there is, in the ophthalmology considered a specialized subject when compared to other general specialties which we are discussing till now. And we have got postgraduate training institutes throughout India, and government has also started a number of MD and DNB seats, college courses has been started at the district level. Every district hospital, they want to start a DNB course to train the MBBS doctors in ophthalmology. And other than this, to reach every village, they may not be able to come to cities to get the eye checkup like that. So for that, we can train the 10th and 12th standards for in the healthcare sector, because the HSSC has recognized these courses like in other specialties. We can train this to do the basic tests in eye testing like vision test and that ocular pressure, that whatever glaucoma, other tests are there, all those things, and cataract they can diagnose, and refractive errors they can correct, all those things. Like this, training can be imparted through optometry training can be given at the basic level. And further, for any surgical procedure is required, they can refer to the district hospitals or peripheral hospitals. Like this, in our artist, we have started artist is the Asian Research and Training Institute for Skill Transfer in Karnataka. We have adopted a number of villages through in different districts, where we have started our health clinic, it's called, where along with eye checkup, we do the glucometer with we will do the sugar test, and BP we will check, and all those will be recorded, and the data will be transmitted through us to the digital system, and we record all the data of all the patients. And whenever the patient requires any surgical or other intervention, we'll refer them to the higher centers. So because of this, the post-COVID, we were faced with some different problems. Since ophthalmology is elective specialty, number of patients of diabetes and hypertension and glaucoma, they never came for follow-up because of the lockdown and other things. They were confined to the house, and when the COVID went off, we started practice. We found higher end stages of diabetic retinopathy where we can't treat the patients, and high end stages of glaucoma where the optic nerve has been damaged, all those things. So all these things has to be taught as a lesson that the primary care at the basic level is more important when compared to the regular higher end centers where the lasers and other treatment are given. So all these different training at the basic level for the workforce is too much. For 10 to 12 standards passed, and there are no other employment, unemployment is there. So for them, if you can take them and train them in their specialty, like doing basic tests, and referring them to higher centers, that will be good. And that will be a good workforce in our country, where the population is so much, and healthcare higher centers are located in the city and tertiary hospitals. So this basic workforce can be created by giving good training. We can give the virtual training there. They need not come to city to get the training. We can virtually transmit and give the training through the digital media like Zoom or some other connections. And that level, in that way, from the basic level, from the village level, sub-centers, taluk levels, if we are to increase the workforce in the healthcare system, and through that we can enforce the basic healthcare system which is prevailing in the country. Thank you very much.
Thank you, sir. Thank you so much for sharing your experience, and it's very nice to hear that you are already carrying on such an activity as we have been doing in the Illness to Wellness campaign. So thank you so much. Now I'd like to come to Dr. Ashish Chaudhary, sir. So I'd like to ask you, as we have been discussing and we've been hearing the figures as well, that it is not that we lack absolute facilities. In fact, in cities, we know in urban centers, the facilities are abundant and they're grossly underutilized. So what can be done in such conditions? Would you recommend some public-private partnerships how can we maximize the utilization of infrastructure which has been already built by private players, and not only hospitals, I mean also physicians, small clinics, primary health centers, because these are also existent and many in number, and yet they are not fully utilized.
Very rightly pointed out, this kind of deficiency we also feel on a daily basis. If we talk about, a glaring example is of the COVID pandemic, where the states were going through the peaks and troughs at various times, but there was intercoordination to continue maintain the oxygen supplies and the medication at the central level was not so streamlined. So while Delhi was suffering from oxygen crisis, Odisha was in abundance. So that kind of status was there. People definitely realized, and a lot of steps were taken by Government of India in that direction to streamline, channelize, and other states come into rescue for the state who is bleeding or suffering from maximum deaths and the morbidity related to the disease. But apart from COVID, on a daily basis, we find, in a tertiary care facility, you would not have all the beds filled up all the times, whereas there would be loads of primary care patients waiting for a specialty treatment at other smaller hospitals. So, as an organization, we came up with a plan to collaborate, coordinate with the neighboring clinics and small hospitals where there is apart from mere financial transaction, there is a motivation so that as a tertiary care facility, we can, impart as simple as BLS training to all those nursing homes where you don't have qualified people, or they may be coming from various backgrounds and don't have adequate know-how of how to manage a situation on an emergency basis. So that education exchange works wonders for them, brings in some quality care at their smaller hospitals. But in the return, whenever they need a specialist, in the middle of the night, or they want to, give the right treatment to a stroke patient or a acute MI coming into their facility because of the proximity and neighborhood, there the tertiary care comes into rescue for them. So that kind of collaboration definitely is going to a big step. We should not be competing with the neighboring hospitals, smaller or bigger. It should become a partner. So if we have to find a patient who needs a urgent liver transplant or a bone marrow transplant, we would definitely seek help from a quaternary center like Medanta or some other place like that. Apart from this, I feel public-private partnership. That's in last few years, government has initiated so many measures. Even on our capacity, we find that so many partnerships started, especially in diagnostic space, where government is outsourcing diagnostics of their tertiary care facilities, and also giving opportunities for the private doctors to come and run their local clinics, like Mohalla clinics have been manned by private doctors. So such initiatives have already started. I feel that it's going to go a long way, and we need to put in a lot of effort from both the sides so that the optimum utilization of the entire staff across the specialities, super specialities should be done so that both public and private organization can be, the efficiency of the staff can be utilized to the maximum, and the ultimate benefit goes to the patient. I heard all the speakers mentioned about various challenges the Indian healthcare system has, but if you go out and see the situation of countries, CIS countries, Arab countries, even the Western world, we see so many patients traveling to India only to get the best cost-effective and a quality care. I mean, combination of a high quality with a low cost. Nowhere else in the world you find this kind of quality, and the comparative pricing is almost 1/10 of the cost if you compare with Western world. So, and COVID was a perfect example where Indian healthcare, despite so much of constraints, so much of population, rushing to all the hospitals, even then the mortality rates were pretty comparable with the Western world, and we fared a lot better because of quickly, gaining the research, protocols from the research going all across the globe, and there are so many indigenous products which came up. The vaccine has proved wonders as compared to other global players, compared with Pfizer, Chinese vaccine, Indian vaccine has done fantastically well, and as a responsible nation, they have spread this vaccine to more than 80 countries. So Indian healthcare way of healthcare, I think I feel it's one of the best, considering the price point, considering the constraints with which the Indian doctors work. But yes, if we scale up on nursing and the medical part, and we optimum utilization happens and public-private partnership becomes the norm, I think nobody else in the world can serve what we can do here.
Definitely, we are providing highly cost-effective medical services. Dr. Clare, sir, would you like to add?
I just want to say one thing more. Another fundamental basic mistake or a deficiency in our system is that, for example, somebody knows Dr. Ashish, he's an orthopedician, the family knows him. If this family in the mid of night have a pain chest or pain tummy or any, they'll call him. Why? Because we don't have a system where to go. So the concept of GP, I think, is very important. Family physician.
Yes.
Now there should be all across the country, there should be areas, there's so many people be looked after by this GP. Like in UK, for example, many other countries, there is a GP system. Now this GP slowly knows the whole family. He understands the problem so easily. And then you can cut down burden on main hospital. Even like, for example, I don't understand why any patient should be allowed to go to All India Institute of Medical Sciences. Even with a simple hypertension, people go there. I see patients from Guwahati and Sikkim, they have just hypertension. They don't need to come to me. So it's just a waste of their time and my time. So if we have a GP, and GP will refer them to the appropriate doctor if need be. Actually, 90% of the disorders he can rectify himself.
Yes,
90%.
Yes.
And we can make an exception only in emergency. Okay, if there is emergency, they can go to the hospital directly, but non-emergency, they should go to GP first.
Yes, and a lot of GPs are already present. I think the suggestion that you have given, using the public-private partnership, their services can be utilized.
For example, what is required GPs in Delhi, they are more than what is required.
Yes.
But you go 100 or 50 kilometers out of Delhi, there is no GP for in two districts. There is no system. So there should be a system by the government of India to produce a GP network all across.
Definitely, I think this is a very good recommendation.
And you know what, the new doctors, for example, if they want to become a GP, they should not be allowed already people working in Delhi. There is already excess of doctors.
Yes, definitely.
They have to select a new place.
Definitely. Dr. Ashish.
So just 2 points here. NHS system works on GP practice. Yes, there are a lot of good points they offer to the population, but the referral to the specialist and the surgeons, at times the waiting time crosses 3 to 4 months. But Indian system is much better. I mean, if we can channelize the basics, the primary health to the GPs, and only the difficult cases gets referred to the specialist, it's going to be a great, boon for our patients. Yes, technology can definitely help. A lot of medtech companies have started doing that. A similar initiative by the ITC company in the name of eChopal was, initiated a few years ago, and they were using their, small little centers to provide the healthcare, to provide telemedicine, portal there, and distribute the medication. So already existing pan-India organizations who already have some distribution network, I think that can be utilized. A fantastic example is in Africa, where ivermectin was circulated through already established food grain distribution network. So those other non-healthcare good, robust logistic networks can be utilized to deliver healthcare in one way or the other.
Definitely. Dr. Wali, sir.
No, I know we are all waiting for lunch. I would conclude by saying that the word GP has a lot of inferiority complex amongst our community. Doctor is doctor. So what I was telling, produce basic doctors which can work anywhere in the India. So these days trend is just to do MBBS. They don't think they have completed the education. The full form of the MBBS should be taught to every doctor in detail when he completes. He is the Bachelor of Medicine and Bachelor of Surgery. That completes his primary curriculum, and we need this today. We don't need the specialist of, sorry for that statement, right eye and specialist of the left eye. These days people are joking that the specialty in medicine has created some problems for them. So basic India needs basic services, as everybody of us will agree, and that would come when a doctor, after doing MBBS, feels that he is a respectable member of the medical world and can discharge with confidence his basic services and should be supported by family, friends, and medical profession. And that's what we need today.
Thank you so much. I think we've had a...
Let me just say what he said.
Yes.
Family, the GP doesn't mean MBBS, sorry. That time has gone. Our MBBS students, I tell you, they are very, very deficient to do anything. No, they need more training. Actually, if you want to become a family physician, then you have to do 3 years of fellowship after your MBBS.
Yes.
Then you become family medicine specialist. Okay, you delete the word GP. If it's an inferiority complex, call them family physician specialist. So that is what we need to produce in the future.
Yes, very, very true. Very true, sir. Thank you so much. All of you, now I would request all of you to give a small message in conclusion, making a capsule of whatever you had in mind, and maybe if there's something which has been missed out, so that that message can be recorded and it can be further. I would start with you, Jawakar sir.
Thank you. I want to conclude that because of this ophthalmology practice, because of digital exposure, some of the earlier speakers have told, we are more used to our hobby, and school children, we are more used to using smartphones like that, so that we are coming across number of refractive errors, and we are confining ourselves both mentally, and our intelligence level has been confined to only digital media. So we should, as told by Rajput in his speech, we should avoid smartphones, and tell our children and advise our children not to use, be with the screen time always from morning to night, be away with the family, be with friends, and talk to them, directly meet them, and discuss with them. That is more useful, and it's a broader way of indulging ourselves and our population. Thank you.
Thank you so much, sir. Thank you so much, sir. Dr. Ashish, your message.
Well, I would like to say that the illness, we discuss a lot about the deficiencies of the healthcare workforce and the challenges Indian healthcare system faces. But I feel with all these inputs we got, and a direction from the government and participation from the private players, and the decentralization of the services and equitable distribution, I think we can achieve a state of near wellness or perfect health. And I'm sure in times to come, maybe 20 years down the line, the hospitals will more or less cease to exist except for the tertiary care surgical procedures or difficult things which cannot be managed at home, and everything will go back to patients' homes, and they will be managed right in their home environment.
We definitely wanted to discuss about the digitization of training and disease management, but we don't have so much time. So, sir, Dr.
See, if I have to give my message,
yes,
I would like the message should go to all Indians that there are 3 things important in life. Number 1 is health, number 2 is health, and number 3 is health. Actually, nothing else is important.
Yes.
Including your wife, including your children, including your girlfriend. Everything comes after health. If you are not healthy, there is no point having a girlfriend. You understand? There is no point at all. So number 1. Number 2 is that India needs to invest in health education and primary health. That's my message.
Thank you, sir. Dr. Wali, sir. And then we'll have conclusion.
My message is very simple. Illness to wellness means I is illness, VE for wellness. So from me, it should go to a team, and I wish team of Dr. Rajput, Anil Rajput, a great success ahead, because he has taken us from I to we, and we means all of us.
Thank you, sir. Dr. Khilani, sir, your
I was the opening
message.
batsman, so I would give some remarks. I think the whole thing boils down to our medical education. Yes. Why I became a doctor? Not to earn money, because I had 2 physicians working close to my house, they were treated like gods. So I thought I should also do something for the society. The medical education has gone to dogs. You are buying degrees for 3 crores. You pay 2 crores, get admission, and it's the responsibility of the whatever system is to give you a degree at the end of 4.5 years. मैंने एक इंटरव्यू में बोला था कि जो आदमी बहुत सारे पैसे दे के एडमिशन लेगा उसका उद्देश्य भी यही होगा कि जैसे ही बाहर निकलता है उसको रिकवर करना. That is one thing. And same thing applies to our nursing profession also. Do we respect our nurses? Let us ask them. And respect comes from good salaries. If you give them 15,000 rupees salaries, how they are going to command respect? As I said in the beginning, in developed countries, if you are not behaving properly, the nurse has power to throw you out of the ICU. That's the thing. So I'll not focus only on doctors. As for the if you give an education which is merit-based, you will have some kind of good quality. If you give nursing education, if I talk of critical care where I breathe critical air all the time, if the ICU outcome is determined more by the quality of nursing care rather than doctors. That's a fact. But have our system focused on that. We treat our nurses like dirts. We think that they'll give injection, then they'll give tablets, whereas they are the people who are actually providing what we call as care. Thank you.
Thank you so much. Thank you so much, all the panelists. I think we had a very interesting and a very fruitful discussion, and we would take all the notes and carry them forward as recommendations. Please.
Indeed, a very, very well-articulated and insightful session that we just witnessed. Thank you, Dr. Kesri, and all our eminent panelists. I would now request Mr. Anil Rajput, sir, to please express a token of gratitude to all our eminent speakers. Can we have the mementos, please?
Hey, I have a question for you. If I were to present you my data in the form of this boring Excel.
Yadav ji, Hema Pawar ji, Rajesh Goyal ji,